something like that. So that would be a nice summary for your history, taking. So this would be a good summary. So this is the prototype. Okay, you can use this one you can vary it. Okay, but always, like I said before, the summary for the history taking is this. Let me put it this way, so that's all that we have talked about will stick. So what I'm saying is, so the summary for history taking is this. First of all, you must take your history, do your examination, and know the condition. So know the condition, know the disease. Okay, you can only know the disease by taking the history. When you know the history, then you come and draw a graph for the progression of the condition or the chronology of the condition. Okay, so the graph is always like that. There's always a baseline to onset, to the time that the patient reports. Okay, it may go up a little to when you get to know. Then you put in your interventions. Okay, here it may depend. It may go. You may be able to stop the condition and then bring the person back to the baseline, or it may go on. You may lose the patient, or so on and so forth. So here is a baseline. Always have a graph. You can just sketch it somewhere. Baseline. You come to onset. So onset, was it abrupt, sudden, gradual, okay, insidious? That means the patient they don't actually notice it. It's just becoming. Okay, and then this is the progression. So the progression is also going to tell you. Okay, the frequency, was it constant, ever increasing, so that's the progression. Okay, so this is the peak of the symptom. Peak of symptoms. Okay, and this is where they report. Okay, when they have the symptoms are severe, that is when they report. Most people will report. Few people will report when the disease is progressing, but it's not so severe to them. When it's so severe, then they will report. Okay, they will report. Right. The progression is another say that. So onset to progression, you can have plus or minus, so associations may come in. Okay, exacerbated by, increased by, decreased by, so on. They will come into the picture here. Okay, until they report. So the first symptoms of will be the primary center. Okay, and then they are referred to either the secondary or tertiary center. Okay, and then we will take it up from there, do whatever we have to do for the patient until we are able to bring the patient back to the baseline, or something happens, we lose the patient, or it takes some time to bring the patient. We will not be able to bring her back to the treatment, but maybe with a certain complication. So this is the picture of how, once you are able to draw this somewhere, sketch this one somewhere, the picture is in your mind. So when you're asked to narrate or say or give out a history, because the picture is there, you start, okay, patient was referred from La General Hospital on account of IBP, that's a presenting complaint. Okay, patient was well until about 3 weeks ago when she noticed her feet were getting swollen. She decided to visit La General Hospital. At the facility, it was detected that her BP was 150, 110. She was told the BP was high and therefore was given a referral note to Koinontigen Hospital. This is a simple one. Okay, so that is the HPC. So you see the HPC. This is talking about the preeclampsia, something like that. So maybe she was told the protein. She was told that the condition needed a referral because they cannot handle it. Then she will be referred to you. Okay, so see that like I've said, every condition will have the same history in terms of chronology. Okay, it will be similar. Okay, it will be close. You can't have history for malaria. That will be the same. What I mean is malaria history is the same. It's fever, chills, general body pains. So you cannot have malaria and say it is what let's say swollen. What do you call it? Foot. No. It is always malaria. So far as the condition, the symptoms will not change. Once you get your impression, let them follow. Okay, let them follow. If they don't follow, it means that is not a condition, right? So that should be there. If it is malaria, your fever this. Okay, unless maybe we have some people who don't have fever, then that will come. Okay, so once you know the condition, know all the symptoms, the cardinal symptoms especially, the other symptoms that will support the complications up to the end. Know everything so that when you are writing a history, so you start from the baseline, onset, progression, reporting, okay, treatment. Treatment was good, everything came up. Treatment was a little good, so complications came. Treatment wasn't good, the patient passed on. And that is how the history should go. Okay, so this is the summary of a good history. The graph is important. Always have this at the back of your mind. Okay, the patient, if you are at the tertiary center, you may see the patient here. If you are at the periphery, you may even meet the patient here or here. Right? Remember, patients will report usually. Always have this. So the most important thing is patient usually will report to you when the symptom is severe, and that is when maybe onset starts from. If the onset was severe, then they'll start at the onset. Unless maybe progression goes to the peak, then they will report to you. So the patient was apparently well until 3 days ago when there was a sudden onset in the sensation of the sudden onset of abdominal pain. The pain was more to the lower part of the abdomen, radiates to so and so, was associated with vomiting, so on and so forth. Patient initially thought these symptoms were resolved, so she went to buy over-the-counter drugs, but unfortunately for her, later in that day, the symptoms became worse. She was vomiting more excessively, and therefore had to be rushed to a nearby facility. Over there, this was done, investigations done, and so on and so forth. And an impression of this was made. She was therefore referred here, tertiary institution, for further management. And also this. So the history should be flowing like that. Baseline, onset, progression, associations, peak of symptoms, reporting, referral, management, complete management, incomplete management with complication, unable to manage patient pattern. That's all. And this is a very good way to approach almost everything in medicine. Okay, in surgery the same thing, in internal medicine the same thing, in pediatrics the same thing, in obstetrics the same thing. Always have this picture. Always have this picture. The baseline can be normal. That is nothing. You can have a particular condition, diabetes, asthma, sickle cell. So those ones you talk about. So once you have this picture in here, you always be able to give a very good picture. So your history, when you are summarizing too, the summary, the baseline must come in. The cardinal symptoms of the disease must come in, and where you've got into in the management of the patient. So you see that the summary is like this: baseline, cardinal symptoms of the disease, where you got into in the patient's management. Okay, and that is what will be for the summary. Right. So this is how it will go. Now let's come to examination. Examination, which is very important. The examination is also going to add more to your history, so that you'll be narrowing down the impressions that you have or the differential diagnosis that you have. Okay, so in most simple terms, usually the examination can be general examination. Then general examination, then you come to your systemic, okay? Systemic examination. Okay, so here we have your cardiovascular, we have your respiratory, we have your abdomen or GI, we have your nervous system, we have your musculoskeletal system. Then we come to what we call status localis. Okay, sometimes it may be relevant in that case. So this is how the order is. You see, I want to make things very simple for you. So if you are reading the textbooks, there are so many of them, and then you don't know how to go about it after reading, especially as a student. You do not even know how the picture fits in the clinical scenario. But always have at least the basic ones like this. So the general examination, your systemic examination. Systemic, you are looking at the cardiovascular, respiratory, abdomen or GI, nervous system, musculoskeletal system. So then your status localis will also come. And sometimes what I even do is on top of the general examination. I will put this because that is what, so that you have everything in there. So let's say my general examination is here. I'll have what you call the emergency management. Okay, so emergency treatment and management. So I always will start with the ABPU. ABPU. You come to your ABC. Yes. Then the secondary survey, which is ABCDE. Okay. And then before you come to your, so that if you have this picture in your mind, no matter the condition given to you, you'll always be able to flow with your examination. Okay, but usually these ones, more or less, I'll also leave them out and then push them to management. Okay, before you start managing the patient. This can sometimes you need to do this before you can start examining. Okay, and sometimes too after doing that before. So usually you can have this picture like that. The emergency management, when the patient is stable, then you come to examine them properly. Okay, so you stabilize the patient. As you do the emergencies, you stabilize them, and then you come to your examination. Okay, so from the examination, then you come to your management. Okay, so from here, you come to what? Management. And the management will involve investigations, okay, and then treatment. Investigations and treatment. Okay, so let's look at this. This ABPU is what? Alert, verbal response, the pulse is there, unconsciousness. So you see the patient for the first time, you have to know whether the patient is alert. The person responds to you when you say something. You can feel the pulse or patient is unconscious. That gives you a picture of how the patient is. Okay, if that is not satisfactory or you've done that is satisfactory, then you come to your airway, your breathing, cardiovascular. So that's the primary survey. And then you do that to see if you as you assess each of them, you correct at the same time you try to correct them. Okay. So here your targets are there. By making sure the BP1 is more than 90-60. Okay. Okay, your pulse is also 60 to 100. Your SpO2 is what? At least more than 94. Okay, so these are the targets. You must have targets. These are the targets. Okay. Sometimes the condition is continuing. So when they are continuing, you either would want to stay here. Okay. You also want to be doing something to be keeping it here or more. Okay. So 90-60 pause this one. You want to keep them there or more or less. Okay. But at the same time, you try to stop what you can stop or move the patient out of. So you first, like you see, always move the patient to a safe place. So safe place first before the emergencies will start. Or you switch off. Sometimes you move the patient to the safe. Switch off the mains if it's to do with electricity. Move the patient to the safe place. AVPU, ABC, ABCD. Then you come to, now the patient is stable. You come to general examination. So I want you to have all these pictures. So that when the patient is, you have told the patient is this, you picture where, which level the person will be, and then you can take it from there and then go narrate, okay? So if you have told the patient came to you, patient was found unconscious somewhere, how would you manage the patient, okay? How would you manage the patient? Talk about, you have to go through these processes, examine, okay, come to investigations, arrive at the investigation, and then make diagnosis, and then go to treatment. Treatment, is it going to be non-pharmacological? Is it going to be pharmacological? Is it going to be surgical? Is it going to be conservative? And so on. Right? Are you going to follow up? Okay. So those things will come into the picture. So this is how you get this part on. Okay. Right. So the targets are very important. The targets you are trying to get very, very important. So let's go back to general examination. So the general examination, you must always have your vitals there, okay? So your BMI, your BP, maybe your vital BMI, maybe sometimes respiratory rate and other things you put there, but depends. Some may reserve it for this one, okay? So your BMI, your BP may be there. This is what you're having. Okay, so here your weight. Okay, and your height is what you are looking at to get your BMI. Okay, great. So that can be calculated. Right. So when you have the vitals stated or the statistics stated, then you come to the general examination. So overall appearance, the patient stable, well looking or not well looking, or ill looking, or wasted. That's a general one. Okay. Then you can talk about something like the general examination. So you can talk about pallor, state of hydration. Okay, pallor, state of hydration. So then you can come to other general things like the anterior neck swelling, anterior neck swelling, any lymphadenopathy. Some will even talk about edema and so on. But you can, at least up to this point, you can even talk about breast. Okay, if you want to do breast examination, maybe under that. These are just depending on the scenario. So this is just to capture something for us and gynecology. Okay, so the vital BMS and so on. Well, not well looking, fibra, infibra, pallor, state of hydration. Okay, anterior neck swelling. There's the breast examination. Okay, so you do that. Then you come to, when you have exhausted these ones, you come to your cardiovascular. So your cardiovascular, talking about your pulse rate. Okay, the peripheral pulse. Okay. Now, first of all, if you want to, so usually we'll start with what we call alpha. Okay, inspection. So on inspection, what are you seeing? Are there any visible pulses, pulsations that you can see? Okay. Then you come to your palpation. Okay, palpation, you're looking at your pulse rate. Okay, maybe the apex beats may be palpated, which level it is, and so on. And then next, parasternal beat, and so on. Okay, and so on. All those things will come into the picture, right? So then you come to your percussion. Okay, so you can do your percussion. Usually under cardiovascular, it may not, but you need percuss to know where the heart is. Okay, area covered by heart. So then you come to your auscultation, where most of the things should be. So auscultation has sounds 1 and 2 heard. Is there any added sound? Maybe S3. That's where you have the gallop reading. Okay, maybe for injection systolic tremor. As in anemia. Okay, you have this one. Okay. Then whether you have MEMS, MEMS or no MEMS. Okay, if you have MEMS on inspiration, expiration, radiation, so on. So this will be under your cardiovascular. Then you come to your respiratory. Okay, the same thing, inspection. Okay, your chest expansion. Okay, expansion. Okay, symmetrical or asymmetrical. Okay, and then you can then talk about maybe shape of the chest, shape of the chest. Is it gone in? Is it projecting out? Kyphosis, scoliosis, kyphoscoliosis, and so on. Right, so then you come to your palpation. What are you going to do? So your inspection, your palpation, together with your chest expansion, is it symmetrical and so on, whether it's expansion or one is open. So then you come to your percussion. Okay, so your percussion notes. Okay, is it resonance? Is it high or is it just resonance? Is it down, stony down? Okay, so on your percussion notes you are getting. So your percussion notes, usually if you are talking about percussion, you are talking about whether it is down or stony down or tympanitic. Okay, sorry for bringing in what you call the auscultation aspect, which is resonance and so on. So here the notes, percussion notes, is it down, stony down, tympanitic? Okay, right. Then you can even under palpation, some may also talk about what whispering pectoral choir. Okay, And then others may also talk about what just because the person talks and then everything vibrates within the chest wall. You can notice that one too, right? Right, so that is the percussion notes, okay? That's tuning down, tympanic, or talking about in terms of resonating or not, right? Now you can then come to auscultation. So auscultation, air entry, is it adequate or reduced? Is it bilateral or on one side? Okay. Then you talk about the breath sounds. Okay, the breath sounds, is it the vesicular in adults or bronchovesicular in children? Is it different thing? Is it bronchial, which is abnormal? And so now you come to the added sounds. Okay, so you are looking at your wheezes, or I would say bronchi here. Bronchi. Okay, bronchi, that is what you hear, the wheezes that you hear with your stethoscope. Okay, is it bilateral and so on? Right, so this is what you are getting. Okay, then you can talk about your the crackles. Okay, whether you are hearing crackles. The crackles can be coarse, can be fine. Okay. So, and then maybe is it bi-basal or generalized? Okay, all those things will come in. So this is the picture. So under auscultation, you have your air entry, adequate or not adequate, bilateral or not bilateral, breath sound, vesicular or non-vesicular. Okay. Then you come to the added sounds. Is there crackles? Is it coarse or fine? Okay. Then you come to your bronchi, the other things that you want to look at. Okay. Is there bronchi or wheezes that is the patient will hear, actually the patient wheezing, or you use your stethoscope to hear the bronchi. Okay. Right. So that is how it will be for respiratory. But of course, before you start the whole thing, it's important to put your respiratory rate there. 16 counts per minute. Okay, regular. Okay, that's average for adults. Okay, so that can be. In children, in neonates, okay, you may get as high as 50 to 60 counts per minute. Okay, while the pulse rate may be 120 and above for neonates. Okay, right. So that is something, but for adults around this. And then the pulse we have said, the pulse rate, and this one you must put there. That means under cardiovascular, you must also remember the BP that you stated, the pulse rate, okay, whether there's physical pulse or whatever, that those ones that you measure also will come into the picture, and so on. Radial, delay, and so on and so forth. So all those things will come into cardiovascular. The same thing, these ones. So you look at the point that you put there. Okay, first the initials of vitals, then the other quantities will come in. Initials of the vital readings, then the other quantities will come in. So when it comes to abdomen, where our focus is, for those of us doing OBS, where our focus is, the same iPad is used. Okay, so inspection, the abdomen is uniformly enlarged, moves with respiration. Okay, there's linear nigra extending from the what do you call it, the symphysis to the pubic bone. Okay, or the pubic level. Okay, right, and then we have other things like the linear gravidarum, okay, or the albicans, because that one has changed. It's an old striae gravidarum, okay. Sorry, striae gravidarum will be there, or you may have the old ones, which is the striae albicans, which is an old scar for the previous pregnancy and so on. Or you may have scarifications, which may be done for traditional reasons, okay? Or you may actually have a scar there, or you may have a cervical scar there. All those coming under inspection, right? And then whether the abdomen moves with respiration, okay? Sometimes you may see fetal movement. So this will add on to what you are seeing, right? Is there uniform alignment? So usually the picture is the abdomen is uniformly enlarged. The linear nigra extending from this to this, okay? We have striae gravidarum, okay? We have scarifications, we have incisional scar, anisal incisional scar, so on and so forth. Okay, so you do your exposure up to the upper part of the thigh, exposing the mons, okay, so that I can see the pubic hair a little, the distribution of hair, is it masculine or the feminine one, so going up to about the wrist to the rising to the umbilicus, and sometimes being above it tells you all that, okay. Then you come to your palpation. So palpation, you have what? Superficial palpation for pain, tenderness, okay. Then deep palpation for the organs, okay. And then you come to your uterus, okay. So the uterus, you want to know your SFH, so fundal height, okay. If it is less than 20 weeks, you just estimate it by or 20 or 22 weeks, just estimate it by weeks. If it is beyond that, you use your tape measure to get the estimation of the length, and this corresponds to the gestational age within +1, +2, +3 to +4, depending on the trimester level that you are, okay. So that gives you the picture, okay. So when you have done the SFH, you want to know the lie of the patient, whether longitudinal, oblique or transverse. Then you come to the presentation, the presenting part, okay. Then when you are done with that, you want to know where what do you call it? You want to know the anterior shoulder. You can listen to the theta. Just a little lateral to the anterior shoulder or over the anterior shoulder. You pick the theta aspect. Okay, right. And then of course we talk about descent. 5/5 means the head is floating. Okay, how much of it is gone in? By having 2/5, it means 3/5 of the head is inside, and at that time the baby's head is engaged. It's assumed the baby's head is engaged, and usually that is what happens in somebody who has not delivered before. Right. So, and at that point, when you have 2/5 out and then 3/5 in, the head, the station, if you are assessing it from the vagina, the station, how high the presenting part is from the ischial spine, it will just be at the level of the ischial spine. I mean, station is 0, right? So that is how you can put the pictures in, and then have a very good listening, right? So that is for the abdomen. Of course, the other organs will be palpated for the spleen, the on the sides, and then the liver on the side, the other side. And of course, by manual palpation of the kidneys also be done. Of course, the equine we check for this, we check for that. And of course, usually vaginal examination and then genital rectal examination, depending on the condition. But usually these are not done. They may be done depending on the condition. Of course, you want to elicit, depending on abdomen size, you want to elicit ascites, and so on and so forth. Okay, sitting, dullness, okay, from fluid through, so on. Right, so auscultation, depending on the gestation, you want to listen to the bowel sounds, the aortic, the abdominal aorta may have some brew, so when they pick up for maybe aneurysm, abdominal aorta aneurysm, so these will come all under this one. Okay, so when you have exhausted this, then you are good to go. The nervous system, the general state, okay, fully conscious, semi-conscious, or stuporous. Stuporous means they gain consciousness and then lose consciousness again. Alright, and then that's the general state. Then you come to what? Your sensories. You come to your motor. Okay, you assess them. Okay, you score them. If there's semi-paresis, you talk about them. So your reflexes will also come in. The tone, the muscles, and so on will come in. Right. So if there's no neurological deficit that is proven, then you come to your musculoskeletal. So you examine the musculoskeletal system as well. Status localis is when you have a condition that you want to focus on, maybe a broken limb or swollen limb, okay, or a particular wound, okay. Then you come to examine the wound. So the wound, you are looking at the edge of the wound, how it's slanting or straight, the base of the wound, okay. So all these things will give you a picture of the type of wound you are dealing with, whether it's a simple wound or a malignant kind of ulcer. All those things will come to the picture. Then you address them. So this will be a good summary of the examination. So the examination, general examination, vitals, beginning, general state, your thyroid or neck, the breast examination comes in. Right, the cardiovascular, you are looking at your BP, your pulse, those peripheral pulses, alternations, okay, delays, okay, radial, and so on, delays, the left and right compared, okay, and then the patient is seated, 45 degrees, or lies down for the BP to be taken, and usually on the left throat, so that you don't compress the inferior vena cava to cause to cover what syndrome, which may lead to what shock. Okay, right. So then you come to your other things: hyper, inspection, palpation, percussion, auscultation, as follows. The same thing: respiratory rate, the count, relevant to the age. Okay. Then you come to any obvious thing that you are seeing, syndromic appearance. Okay, inspection, palpation, percussion, as we have stated here. Come to abdomen, the same inspection, any general thing that you are seeing, inspection, palpation, percussion, auscultation, right? Nervous system, the same thing. You go through the general state, sensory, motor, reflexive, tone, and so on, right? Then you may even talk about the eye, examining the eye, the ear, and so on, for bone conduction and then air conduction, both ears, so on, balancing, so can all be checked for the ears. The eyes, the sight, okay, short-sightedness, long-sightedness, okay, and so on and so forth. Check. Okay. Then come to my skeletal system, the same thing. Status localis, if it's involved, then you look for that organ, that part of the affected organ, and then deal with it finally, right? So when you have done all the examination, you will then have another summary where you combine the history, so the cardinal symptoms of the history or the symptoms, then combine with the cardinal symptoms that you pick up on examination, and then up to the base that will give you the summary. Then you give your differential diagnosis in order of importance, the one which is most likely in that order. Right, so this will bring us to the end of the examination aspect. Right, so just last bit, under the general examination, some will talk about so many other things that you may look out for. You may also examine the fingers, okay, while you are looking at clapping. Splinter hemorrhages, okay, cyanosis. So on. Okay, so all the peripheral signs, so under general and then peripheral signs, okay, all those things will be put under peripheral depending on the condition. Right, so those ones can also come in depending on the condition. So remember, this is mainly for obs and gynae, but if it becomes necessary, these things have to check. Okay, chorionuclear and then those things, so nuclear and then those things coming in for iron deficiency. Then you may need to capture all these under the general examination. Right. The next thing that we're going to do, we are now coming to, we have made our differential diagnosis. So we have our differential diagnosis. So once you have your differential diagnosis, the next thing is you come to your management. So management, first of all, is in investigations. Investigations you are going to do, then you